One. Hello, we're glad you've joined us for this live keynote webinar, the Laboratory Clinical Partnership Opportunities and Challenges. My name is Donna Del Monte and I'll be moderating the session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars, advancing scientific collaboration and learning. It's brought to you by Roche Diagnostics. As a global leader in healthcare, Roche Diagnostics offers a broad portfolio of tools that help healthcare providers in the early detection, prevention, diagnosis, and treatment of diseases. In molecular diagnostics, Roche Diagnostics is driven by a vision of working with laboratories like yours to improve the medical value you offer in virology, women's health, microbiology, genomics, and oncology. The company continues to meet unmet needs through its investment in research, innovation, and scientific excellence, with the goal of supporting your important role in improving patients' lives. To learn more, visit usdiagnostics.roche.com. So let's get started. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. You can pose questions to the speaker throughout the presentation while they are fresh in your mind. To do so, simply type them into the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at the lower left. I now present today's speaker. William Valenti, MD, is Senior Vice President of Strategic Advancement, Staff Physician, and Chief of Innovation at Trillium Health, Rochester, New York. He oversees Trillium Health's research programs and new programs, service development, and implementation. He is the co-founder of Community Health Network, a Trillium Health legacy organization, and has been doing HIV medicine and primary care since the early 1980s. His clinical interest focuses on streamlining systems of care to ensure accessible and affordable health care for all patients. Dr. Valenti believes that our understanding of population health should translate to the care of individual patients. His mantra is that you need to practice in the setting that you supervise. He did his postgraduate training in internal medicine, primary care, and infectious diseases at the University of Rochester Medical Center Strong Memorial Hospital. He is Clinical Associate Professor of Medicine at the University of Rochester School of Medicine and Dentistry. He is Chair of the Infectious Diseases Committee of the Medical Society of the State of New York, and most recently served on the New York State Health Department's task force to end the HIV epidemic by 2020 as co-chair of the Medical Care Committee. Dr. Valenti will now begin his presentation.
Great, thanks, Donna. Thanks, everybody, and welcome. Let's just jump into these slides. And for objectives, here's what we're going to do. And I'm going to leave time for questions at the end, so please ask questions and make comments, because this is, I think the lab clinician collaboration is important. So we'll talk about some opportunities there and talk about the lab role in improving patient outcomes. A little bit about some reimbursement challenges that we've faced and have resolved, in fact. So let's go some quick opportunities. These are some things that come to mind, things that have really been important in our lab setting, clinical setting, to make patient care better. One is co-location. The lab patient service center is right in our clinic. This improves patient adherence, makes sure that patients actually get their blood drawn before or after the visit, and it's just extraordinarily convenient. In the era of electronic health records, online ordering, and we've been able to link the lab's database to our electronic health record so that we can both order from the record and also lab results come back into the record for our review. Customer service is important. I'll talk some about this, give you some examples, but I'm in regular contact with our lab reps, and we also have a staff member who is a liaison between our clinic and the lab, so that we can get answers to questions quickly. And I think quick response is really important here. Things like alerts during business hours versus off hours. Lab calls us with alerts or out-of-range values, and we get urgent results, canceled test reports, those kinds of things, so that there's a pretty regular stream of communication that I find very, very helpful in terms of taking care of patients, which is what I do. Well, here's some reimbursement challenges that we faced recently. Maybe an opportunity, too, for many of you who are watching this. We were recently designated a federally qualified health center, FQHC. And one of the things that is required in that rubric is a sliding fee discount for patients. It's based on household size and income. And the requirement for us is that all of the partners and referral sources that we use need a similar sliding fee scale that's based on income and household size. Reduces the cost of care for people and eliminates some of the out-of-pocket expenses, so it makes care more affordable. Now, without the sliding fee scale by our lab, we would have needed to partner with another lab, so you can imagine that we worked very hard at preserving the relationship and going through all of the channels to make sure that it passed muster, and it did. So the lab sliding fee scale is now into effect, and one of the things that it does is it makes the testing component of the care that we give more affordable for patients, avoid sending patients to collections, patients keep their appointments, get their labs done, and I think in many ways helps improve patient outcomes. So a little bit about how I view my world and my fellow providers. In general, providers, when interfacing with the lab, are more concerned about the availability of the test. Are you doing the test that I need for my patient? Or do I have to send the patient off someplace else? So availability, timely reporting, absolutely critical, and I'll give you an example of that in a minute. And then, because we link test results to care. I mean, I make clinical decisions all the time based on laboratory results. In general, we're less concerned about the test platform, the machine that's used, the mechanics behind it, less concerned about that, and less concerned about the methodology. So give us results, but I think it's important to sort of give those results and have those activities centered around the way people think. So let's talk a little bit about some advances in technology that help improve patient care. Here's another discussion of how I think. I think in clinical terms, and when thinking about sexually transmitted infections, I think very simply, and I think logically, in terms of body site and disease state. Give me a throat culture for GC, urine, urethra for chlamydia and gonorrhea, rectal for CTNG, cervical for CTNG. Just very, very simple. Now, here are some of the challenges that we've faced, because this is not how I think. This is a dizzying array of something that popped up in a patient summary as I was reviewing a record to get this talk ready. And it kind of looked at it and thought, you know, this really doesn't make sense. There's no logic to the way it's ordered. We have trouble with the numbering system. I'd rather have things come out in alphabetical order because that's how another way how I think. But gonorrhea is spelled the English way. It's spelled two different ways. There are a lot of there's a lot of discussion about the test methodology and platform. And so if when I went back and looked at this and then tried to compare it to the results in the chart, I found this. Now here's another dizzying array of results they come back to a template in the chart, and you can see that it defies my logic. So we have worked on, and worked very diligently, in terms of organizing lab results when they come back into the electronic record and organizing them in a logical fashion so that they make sense clinically and that I can make clinical decisions based on what I view. And sometimes I view this in a hurry and rely on other people to feed me information. And when I go back and look at something like this, don't know. The good news is we've been able to work it out, and we have ordered the templates in logical terms and in a clinical format. Another opportunity is to think about responding to trends in healthcare. I'm going to sort of present this in an infectious diseases, HIV framework, because that's how I spend most of my time these days. But HIV is a very dynamic discipline, HIV medicine, and there's a lot happening like a fast-moving train on many days. But some trends in HIV care include now recommendations for treating all HIV-positive people with antiretrovirals, regardless of CD4 count or viral load. That CD4 count versus viral load is another hot topic of discussion. I'll go into this in some detail, but in general, we are relying less on CD4 counts for our patient monitoring and much more on viral load to follow treatment on antiretrovirals. And also, I'll talk a little bit more about this in terms of some of the newer strategies to identify infection earlier. One of those is, in the HIV prevention world, is a biomedical strategy, and I'll talk about this in more detail later. Pre-exposure HIV prophylaxis, PrEP, which involves 1 pill a day, a biomedical approach, 1 pill a day to prevent HIV infection. The other big trend for us has been with hepatitis C. And with the advent of new drugs, shorter courses of treatment, hepatitis C virus is a curable infection today. And it has been a dramatic game changer in terms of the way we manage hepatitis C, the outcomes with HCV, as these new drugs have come through the pipeline. Another emerging infectious disease is the Zika virus, just another opportunity to begin to think about diagnostics. There's no commercially available diagnostic for Zika. Right now it's available through our state lab. But as emerging infectious diseases like Zika gain a foothold, there are more opportunities to incorporate those kinds of diagnostic tests into our workflow. So think about some trends in terms of incentives aligned. We all want to do a good job for taking care of patients, but sometimes the ways we work aren't quite aligned. And I am a firm believer, and our lab people agree with us, that the lab workflow really needs to be in sync with our clinical needs. An example, we have begun to pay close attention to early HIV infection, the HIV seroconversion syndrome called acute HIV infection, or AHI, includes viral load testing as a part of the diagnostic. I realize that HIV RNA is not FDA approved as a diagnostic. We'll talk more about this a little bit later. But the problem was that our Tuesday night clinic, which is an STD clinic and also now a PrEP or pre-exposure prevention clinic, requires that we have access to viral load testing results quickly. And the lab was able to do another run on Wednesday morning so that we'd have results the next day. So they're now doing viral load testing for us on Monday, Wednesday, and Friday. But in other words, adjusted their workflow and activities to accommodate our clinical need. And that has been a lifesaver, certainly for our clinical program, but it's also helped a lot of patients. Just a quick point that I thought about in terms of, do you know how your customer's clinical setting is organized? We talk a lot about this with our lab because we have providers. We have 2 clinical pharmacists who work right in our clinic, liaison between clinic and pharmacy and lab. And our nursing staff are very active in terms of laboratory ordering through standing orders, and also organizing results and getting results to us quickly. So it's a very dynamic, multidisciplinary activity that we have going on there. The electronic record. I love technology, I really do, especially when it works. Sometimes it doesn't always work, and I thought that maybe we could eliminate more paper than we did with the electronic record. So this is a plea to avoid paper at all costs and really make sure that that lab interface works and that the results come back electronically, and avoid, well, save a tree, but also avoid the redundancy that comes along with sending results both by the electronic interface and also on paper. So, some relevant areas of investigation in HIV medicine today. Post-treatment controllers, we're still trying to understand why some people really never progress to AIDS from HIV infection and have high CD4 counts. Even though these people need to be treated, there's a unique opportunity there to have a better understanding of the immune system that might be applicable to a cure strategy or even vaccine. The HIV eradication cure strategy is really a very active area of investigation. This speaks to our understanding, better understanding of the HIV reservoir and trying to actually do a sterilizing cure. Active area of investigation. Along with that is the use of a single copy HIV RNA assay, which has great appeal to me. This is a very seductive kind of idea for those of us who have been doing HIV medicine for a long time. I realize that it's not available as a clinical diagnostic. It's still very much a research tool, but a very active area of investigation, again, as we try to characterize the HIV reservoir in an effort to see if we can actually do this sterilizing cure. So lots of activity in that area. Another area that I'm going to talk more about, and then I'll come back and forth in this discussion, is modern era HIV prevention, the biomedical prevention, pre-exposure HIV prophylaxis, or PrEP. Very, very active in terms of HIV prevention. So let's rethink HIV a little bit here and talk about some of the modern era trends in HIV care on my side that also have some, in fact a lot, of relevance to what goes on in the laboratory and how we use the laboratory and how we collaborate. Treatment cascades. You may not have seen this, but I have a couple of slides. This is the United States treatment cascade. This is our starting point here in terms of numbers of people who, with HIV, who are diagnosed, who are aware of their diagnosis. The numbers in the last year or so have been a little bit higher, but you can see that as you go through this cascade from numbers of people diagnosed to those who are linked to care, retained in care, on antiretrovirals and have viral suppression, that it decreases to about 25% of United States patients who have HIV actually have a suppressed viral load. Implications for the lab, well, on the diagnosed side on the far left, a lot of HIV tests that still need to be done if there are 1 million or so people with HIV who do not know their HIV status. Point of service testing, rapid testing, a huge, huge opportunity. And we do this, and our lab also does a fourth gen test and I'll show you the schema in a minute. The opportunities for viral load testing, as we try to increase that number on the far right from, it's now about 30% of all people in the United States with HIV have an undetectable viral load. But as we talk about ending the HIV epidemic, there's considerable work to be done here, and certainly opportunities for testing, getting results back to providers quickly, interfacing them with the electronic record. Next slide. Oh, I have control here. I'll do it. I'll take care of that. Well, here's another cascade. The one I showed you previously was for the United States. This is New York State's cascade of HIV care from 2013. It's similar to the previous slide for the US. It gives us some benchmarks, though, for those of us in New York, so that we can see where we are and how well we're doing. You can see that about 130,000 people with HIV infection as you go down through this cascade. You can see that about 70,000 of those people are viral load suppressed, which is about 55% of the total population. It's better than the US as a whole. But there's still a lot of work to be done. It's only 55%. What about the other 45% is the question. The HIV epidemic strategy in New York State, and actually in the United States, really requires that we get on this and do a better job of retaining people in care and viral load suppression to the lowest level possible. So that's what's happening with some of those strategies. It leads into this discussion of ending HIV as we know it, and I'll get to that in a minute. So HIV modern era, the goal of treatment today is an undetectable viral load. And it's not just for the clinicians and the patients. We have social workers and care managers, and the mantra for them is the same. The goal, the reason you're doing housing or helping this patient with housing, insurance, or employment issues is to get them to an undetectable viral load. It's a multidisciplinary effort and is becoming a global effort. Biomedical HIV prevention, as I said, PrEP, is really on the radar screen. I'll give you some details on that in a minute. Here's the modern era agenda, though, for HIV. It's ending the epidemic. And here are just three examples of plans that have been developed in recent years that speak to that. On the left, National AIDS Strategy for the US, which is updated to 2020, so it's got the White House on it. That's the US plan. They're similar. I'll give you the detail in just a second. And the epidemic, End AIDS, the yellow report is the 2015 blueprint from New York State. Is a statewide effort to reduce the number of new infections in New York State to under 750 per year by the year 2020. That will be a remarkable public health achievement. There are currently 3,500 new HIV infections in New York State. So it's a statewide $200 million effort to do this. Bottom is the fast track plan of the World Health Organization. They say by 2030 we can end the HIV epidemic globally. Really ambitious efforts, and the laboratory is pivotal in these efforts. Here's the New York State plan, and the HIV epidemic by 2020, ETE 2020 is what we call it. And there are three key points. Identify and test people who do not know their HIV status. Opportunity all over the place, hospitals, admissions, hospital emergency departments, urgent care settings. In fact, a couple of our urgent care settings in our area have referred patients to us. And they do, because they do rapid testing on site there. All right. If the individual is HIV positive, link them to care, retain them in care, remember those cascades, this is what the cascades are about, and achieve an undetectable viral load for all. And then the big new kid on the block is PrEP for high-risk negative people. I'll give you some detail on that in a minute. I keep saying I'm going to give you detail, and I promise I will. Just a little bit about modern era monitoring now in this, within this framework of ending the epidemic. These are guidelines from the New York State Health Department. CDC says the same thing. This is from January 2014. What that first bullet says is that routine quarterly CD4 monitoring really isn't recommended anymore. That quarterly monitoring doesn't really tell us what we need to, because the antiretrovirals, modern era antiretrovirals just work so well that if people take them, it's really viral load, second bullet, that is the most meaningful measure of effective antiretroviral therapy. And that CD4 counts sort of tell you where you've been, but viral load, HIV RNA tells you where you are. It's a very different approach in this modern era. And as we move toward 2020, there's going to be a lot of HIV RNA testing and some CD4 monitoring, but not the way we used to. Earlier treatment on the radar screen. Finally, the pendulum has gone back and forth over the past 30 years on this, and we no longer wait until the CD4 count drops below a certain level. In other words, offer antiretrovirals to everybody who's ready. I mean, treatment readiness is important here, and we work on that with patients. But the idea is to offer antiretrovirals to all HIV positive people regardless of CD4 count or viral load. Implications for the lab, as I said, fewer CD4 counts, but more HIV RNAs. The other thing that we're doing, as I mentioned earlier, was hepatitis C testing. And also the Roche assay is now, the HIV RNA test is approved as a diagnostic. So the situation and the story is evolving very quickly. But about 40% of our HIV patients are hepatitis C co-infected. So we're doing a lot of co-infection treatment. And as I said earlier, hepatitis C, if done correctly with modern era drugs and monitoring, is curable. So this new agenda, ending HIV, is it realistic? You know, I think it is. I think that we really need to have a coordinated effort and rally around this elimination of HIV infection, or certainly reducing infections below a certain threshold. If we don't get to 750 in New York State by 2020, I bet we'll come awfully close. So there's this biomedical or functional cure. That's the treatment cure with in HIV people who are taking antiretrovirals. I'll talk a little bit more about stopping transmission, but if your viral load is under a certain level, generally under 400 in some of the studies that have been done, but in other words, undetectable viral load prevents transmission of HIV. It prevents forward transmission. We call that treatment as prevention, and certainly has a serious important impact on morbidity and mortality. Some active areas of research in the HIV prevention area, as I said earlier, include pre-exposure prophylaxis. Vaccine is still on the radar screen. It's going to take a little while, though, for a vaccine to be developed. So in the meantime, PrEP, or pre-exposure prophylaxis, which is 1 pill a day to prevent HIV, is as good as a vaccine, and it's pretty good. Here it is. So this is the Gilead drug Truvada. It's 2 antiretrovirals in 1 pill once a day. And as I said, it's the next best thing to a vaccine. If you take a look at the eligibility for PrEP, I know this is a kind of a busy slide. The important thing about this slide, though, is that it digs into testing in clinical terms. And if you look at option 3 on the right, you'll see that this CDC algorithm that talks about PrEP eligibility talks about the testing schema that starts with rapid testing, with then a differentiation test if necessary, and then speaks to HIV RNA testing. So it's on the CDC and New York State Health Department's radar screen. So and I think you have access to this slide set. So this is worth looking at in terms of the eligibility for PrEP. I'll give you the simpler version right here on this slide. First of all, the data, the evidence for PrEP. Once daily, that 1 pill a day. There are many, many clinical trials that have been done. The best one was the Grant's 2010 summary of this IPREX trial, which was a global trial of several thousand patients, placebo-controlled, so it's a good trial. Showed a 90% reduction in HIV infection in those people who took PrEP, who took it. They measured blood levels of Truvada, so they were able to tell who really took it and who didn't. So if you take the drug, it works. And has a significant impact on reducing new HIV infection in high-risk people. Most of these people were gay men or men who have sex with men in this trial. Another trial, observational, from Kaiser Permanente in the San Francisco Bay Area, 2015, no new infections in this observational trial of several thousand people who took PrEP. It works. It does. Who are the candidates for PrEP? Well, men who have sex with men. Men who have unprotected anal sex, that is, anal sex without condoms. Transgender women, significant risk situation. They have 50 times the risk of acquiring HIV over time compared with men who have sex with men, non-transgender men. Mixed status couples. 2 men who have sex with men, 2 male partners, one is positive, one is negative. The negative partner, definitely a candidate for PrEP. And we talk about this with the partners, negative partners of our patients all the time. Heterosexual, especially those who are trying to conceive. We have made several babies in our HIV population, where generally a man with HIV on treatment, undetectable viral load, and his female partner, HIV negative, goes on PrEP, and we've seen some good results with that. Injection drug users also, although injection drug users, because of the availability of syringe exchange and clean needles, are a little bit lower on as a risk group for HIV infection these days. Nonetheless, people who are actively using drugs are good candidates for PrEP, and it's worth having that discussion with them. I mentioned treatment for prevention a little bit earlier. There's a great global trial, this HPTN 052 study, that looked at early versus late initiation of antiretrovirals. This sort of put the discussion, the argument to rest in terms of when to start antiretrovirals. As I said earlier, the pendulum has gone back and forth over the years in terms of when treatment should be started. But the people who were started on treatment as soon as they were identified or as soon as they came into the trial had a 96% lower risk of HIV infection than those people whose treatment was deferred until their CD4 counts fell below 300. In other words, there's really no reason to wait. I realize there are insurance issues and other treatment readiness issues for people. We work through that and really get people ready for treatment as soon as possible. So the study really does support the case for earlier treatment, and it obviously has benefits to the individual patient, but also a public health benefit in terms of reducing the risk of forward HIV transmission. And that's what these end the epidemic strategies are all about. So early treatment equals HIV prevention. Great, great study, and welcome in this modern era of HIV. Well, the other thing that's on the radar screen that has direct relevance to us clinically as well as to the laboratory is acute HIV infection. Remember that there are about 55,000 new cases of HIV in the United States every year. And many of them have what we call acute HIV infection. That's why I cleverly titled the slide, Hiding in Plain Sight. A lot of these people end up in emergency rooms or urgent care settings with this flu-like illness that's called a flu-like illness, and they're signed out and their HIV infection goes unrecognized. So here's a case study, somebody we saw at the end of last year. 26-year-old man who has sex with men came in for PrEP. And he sounded like a pretty good candidate for PrEP, but as we talked to him, he gave a 3-day history of fever with a rash on his back and on his chest. Did a 4th-generation point-of-service test, the rapid HIV test, and it was positive. Lab did the multi-spot differentiation test quickly. And we started him on 3 drugs that day because there's some evidence to say that if you can identify people in this acute seroconversion phase of HIV, that you can actually change the course of illness over time. They may not even need therapy for the long haul. It's still an area of investigation. But the point is, we, in collaboration with the laboratory, were able to get results that resulted in a really rapid clinical decision. Next day, his viral load came back. Next day, his viral load came back greater than 10 million copies. So it was acute HIV infection. It was as though he wrote the book on it. But we were able to work with the lab, get quick results, and make clinical decisions quickly that will likely change the course of illness for this patient. Improved diagnostics are really critical here, and have just been huge, huge game changers in all of this. So going from right to left, first, the numbers are the generation of the tests, 1st through 4th. I like the 4th-gen test with P24 antigen. We were using P24 antigen 25 years ago as a surrogate for viral load before viral load testing was available. I know it may not have been as relevant as we thought back then, but 25, 30 years later, it comes back incorporated into this point-of-service 4th-generation test. So at least we've been validated that way. But anyway, you can see that that dashed line in terms of days after HIV infection when the test becomes positive. Nucleic acid testing, or HIV RNA, is the current gold standard. We use both. But in order to really close that window completely, CDC, New York State Health Department say consider HIV RNA if there's any doubt, for example, discrepant results in the screening test versus the differentiation test, or indeterminate results on one or the other. The other thing is the confirmatory test is the differentiation test or viral load. I'll show you the schema in just a minute. But we really have eliminated Western blot, and the recommendation is that Western blot testing is no longer relevant in this modern era. It just takes too long to become positive and doesn't meet the needs of modern era HIV care. Just very, very quickly, how did we discover HIV infection? As I said, it's been hiding in plain sight. And that's because of the history of HIV starting on the right in the 1980s. We first became aware of the disease AIDS, the sickest people. It wasn't until the 1990s that we got a better handle on the clinical latency piece of this, the asymptomatic HIV infection, which is obviously a huge piece of this. But as diagnostics have gotten better, as we started to talk about ending the epidemic, as the drugs have gotten better, better tolerated and able to be used as a lifetime regimen, we've finally been able to settle in on and identifying and better characterize acute HIV infection. So it is definitely on the radar screen, and we need to accommodate that in this clinical laboratory interface, because it's becoming a big piece of what we do. Here's the CDC testing algorithm. Again, I'm not going to walk through this except to say, look at the far right. It begins to talk about indeterminate results that lead people to an HIV RNA assay, a big piece of modern era HIV diagnostics. One last slide here. So this is just to wrap up the discussion on acute HIV infection. Remember, we used to call some of these indeterminate or discrepant results false positive HIV. Well, not anymore, because we really need to rule out acute HIV infection. And this language comes from New York State Health Department's recommendations, clinical guidelines activity, that talk about obtaining a plasma HIV RNA test. Do the RNA assay to make sure that we are really talking about, is it a false positive test, or does this represent acute HIV infection? Now, they refer to the Western blot there, but as I said, the Western blot test has all but disappeared. So I'm going to close. Just a little quick summary here. This collaboration that we've been talking about needs to reflect contemporary HIV care or clinical needs in general. On the HIV side, the question is, there are incentives aligned to end the epidemic and really optimize clinical outcomes. Access to new technologies is important, and getting that rapid fourth generation HIV test on site has been very important to what we do. And if we can't do the rapid, we can always send it to the lab because they do the fourth gen as well. Remember, I talked about timely results, but the real bottom line here, the unifier, is regular communication between clinicians in the laboratory. And as I said, we have a number of people in our clinic who interface with the lab on a regular basis. And in fact, I talked to our lab director just yesterday about a couple things, and we troubleshot a couple things and got it taken care of. So the communication piece, absolutely critical. I will stop there, take a breath, and see if there are any questions.
Well, thank you, Dr. Valenti, for your presentation. A quick reminder for our audience on how to submit questions. Simply type in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. I'll answer as many questions as time permits. Dr. Valenti, the first question we have is, what strategies have you seen to be effective at retaining patients in care?
Well, retaining patients in care, great question. Big part of end the epidemic. And see, a lot of us pay attention to, well, what goes on at the end of the stethoscope, write a prescription, and you're out the door. The real heavy lifting beyond what I do comes from this multidisciplinary team that I work with: social workers, nurses, clinical pharmacists, lab. But overcoming barriers to care, or the social determinants of health care. Housing. Housing is health care. If you don't have a place to live, it's unlikely you're going to have clean water, and unlikely that you'll miss your medicine. In fact, I saw a case just the other day. Health insurance issues. Overcoming barriers to health insurance, getting people signed up on insurance, and also getting them plugged into insurance that works for them. High deductible insurance plans for some people are like having no insurance at all. So we do a lot of insurance and navigation. Food. We have a food bank in our with our program, so that we also do some meals during the week, a congregate meal. In other words, overcoming some of those social determinants, things that keep people from getting to their appointments. Transportation. We give out a lot of bus passes. Medicaid in New York also has a taxi service that is covered under Medicaid. You know, those kinds of things that are more than just writing a prescription and listening to the patient's lungs, but addressing some of those other social issues that need to be addressed. Remember that a lot of HIV people are from minority populations, they're marginalized, a lot of other issues that keep people from accessing care and staying in care, staying connected to care.
Okay.
What else?
What tips do you have on how clinician groups or labs can contribute?
What? Say again.
What tips do you have on how clinician groups or labs can contribute?
Can contribute. I think I'm not sure. Let me see if I understand the question. The lab clinician contribution to what? Ending the epidemic, talking to each other and working together. You know what else, though? The thing that does come to mind is HIV testing. Screening people for HIV, whether it's point of service or sending it to the laboratory. The other thing that's difficult for people to do sometimes is a sexual history. Sometimes it doesn't take much more than just asking people if they're sexually active and if they have sex with men, women, or both. I hope I'm answering the question, but anyway, I think these things are important, so thanks for bringing up this contribution piece. And also, the other thing that is important here is the linkage to care. That if you don't do, for example, one physician group doesn't really do HIV care, they could be doing HIV testing, referring people to the lab for HIV testing, and identifying or being familiar with a provider in the area who does. The other thing is, think HIV prevention, think PrEP, and at least know that there's one pill a day that people can take, high-risk people can take to prevent HIV infection.
Okay. Well, thank you, Dr. Valenti, for your presentation. I'd like to ask if you have any final comments.
Well, yeah, I do. The part about collaboration, in terms of staying in touch, we used to, this reminds me, we used to do a quarterly lab conference with our lab people and our providers. And I think we should revive that. So we're going to do that. But the other thing is, my experience recently in going back and forth with the lab director on a couple of service issues, what made an impression on me was, first of all, number one, she responded quickly. And number two, by the end of the day, she resolved the problem. Now that's good service.
Okay. Well, I'd like to thank the audience for joining us today and for their interesting questions. We'd also like to thank our sponsor, Roche Diagnostics, for underwriting today's webcast. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. This webcast can be viewed on demand through October 6, 2016. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.